Greetings. Let us talk about the pathophysiology of hepatorenal syndrome. These are my acknowledgements, and please take time to read this notice. And whenever you see a patient with cirrhosis and ascites that comes into the hospital for whatever reason, bleed, encephalopathy, or infection, keep an eye on the serum creatinine. If the creatinine jumps by about 3.3 milligrams per deciliter in 2 days, you suspect acute kidney injury. And if the raise is less than twofold, it is stage 1. 2 to threefold is stage 2, and threefold or higher is stage 3. When it comes to the pathophysiology of hepatorenal syndrome in cirrhosis, I want you to keep these three figures in mind: cirrhosis of the liver, splanchnic circulation, renal perfusion, and kidney function. So, in cirrhosis of liver, there is resistance to the portal flow at the sinusoids, and in addition to obstruction, release of nitric oxide, gut bacterial translocation, all these factors lead to splanchnic congestion that triggers neurohormonal activation, and as it gets worse, it can lead to renal vasoconstriction, and when the vasoconstriction is severe, it could precipitate hepatorenal syndrome. So this is the basic principle. These are the basic principles to keep in mind, but let us go into a little bit of depth. So here is a cirrhosis of liver in the early stages, not advanced. There is resistance to flow at the sinusoids, resulting in splanchnic congestion, and that leads to decrease in effective circulating volume. Whenever there is a decrease in effective circulating volume, the body tries to regain that because it's important to keep the circulation going, and it activates sympathetic renin-angiotensin-aldosterone system and arginine vasopressin system. That activation leads to its effect on the adrenal gland and kidneys to retain sodium, and it increases the effective circulating volume. That in turn increases the cardiac output, increase splanchnic flow, and then tries to maintain it. But as this vicious cycle continues, there is increase in extracellular volume that is manifest in patients with cirrhosis, with portal hypertension, with the development of ascites. So, as the patient starts worsening, as the liver condition starts worsening, this vicious cycle continues to worsen with further decrease in extracellular volume, further activation of sympathetic renin-angiotensin arginine vasopressin system, and further increase in retention of sodium, resulting in recurrent ascites, refractory ascites, and even more retention of water, leading to hyponatremia and resulting in ascites with hyponatremia. As you see a patient with cirrhosis and you see ascites that is getting difficult to treat and hyponatremia is setting in, you have to think that this vicious cycle is getting worse and worse. And if for some reason, either because of continued worsening of the liver status with the decompensation, further and further decompensation and worsening splanchnic congestion, resulting in decrease in extracellular volume, or because of either a bleed or fluid loss from the kidneys because of excessive diuretic use, from the gut because of excessive laxative use, or some form of diarrheal illness, or any other reason for extracellular volume decrease because of an infection, it can further activate the sympathetic renin-angiotensin and arginine vasopressin system. As this is going on in advanced cirrhosis, as the disease progresses, the cardiac output that has been at a higher level initially, the hyperdynamic circulation that we know of in patients with cirrhosis, as the patient develops cardiomyopathy, cardiac output starts decreasing. And then it reduces the renal flow. So on one hand, you have decreased cardiac output and also increased sympathetic renin-angiotensin arginine vasopressin system. These two things result in worsening renal vasoconstriction, worsening renal flow that eventually leads to hepatorenal syndrome. That's when patients with cirrhosis with ascites develops hepatorenal syndrome. So this pathway is important because you could treat this by correcting the extracellular volume, decrease the effective circulating volume by giving albumin, and increasing the perfusion of the kidney uh, by increasing the blood pressure, by giving vasoconstrictors, either norepinephrine or recently terlipressin has been approved by the FDA. So this is what you do, and you also correct the reversible factors. If there's a bleed, you need to control bleed. If there's infection, you control the infection. If there is a fluid loss, you stop the diuretics, you stop the laxatives. You may need to hold off the beta blockers. You may need to hold off the ACE inhibitors or ARBs. Uh, uh, and you have to also rule out other causes for kidney injury as you try to manage patients with ascites and acute kidney injury and hepatorenal syndrome. I hope this is helpful. Thank you.